Anderson, the Chief of the Child and Adolescent Protection Center here at Children's National, and I'd like to welcome our guests who are joining virtually for this Regional Academy on Family Violence lecture series. We are so honored to have Dr. Jackie Campbell as our presenter today. Dr. Campbell is a professor at Johns Hopkins School of Nursing and a national leader in research, advocacy, and policy development in the field of violence against women and the health outcomes associated with it. She is an academician with numerous federally funded research initiatives through the NIH, Department of Defense, CDC, and others. And her work has really paved the way for a growing body of interdisciplinary knowledge about the experience of violence and physical and mental health outcomes, risk assessment for lethal and non-lethal domestic violence. She is a member of the American Academy of Nursing and the National Academy of Medicine. So we are in the presence of greatness for sure. I just want to express my sincere appreciation for her willingness to join us in this format. Even though we are local, we're still in this virtual space in hopes that we can reach a larger audience. And so with that, I'm not going to belabor anything and give as much time to Dr. Campbell as I possibly can as she presents to us on intimate partner violence related maternal mortality.
Well, I am absolutely delighted to be with you. I'm a big fan of the Children's Medical Center for many reasons. I am, oh, no, I've got, there it is. And I hope everybody can see the slides. If you have questions, please put them in the chat. Hopefully I'll get finished in time to do a little bit of questions at the end. If not, we'll go through the chat and I'll do some response by email later. One of the things I always like to start out with is land acknowledgement. These are the lands in Maryland. And I know you folks sit on DC, I could do it there. But I think the important piece of this is the idea of the missing and murdered Indigenous women. Their website is down there below. I think it's really important, highly relevant to what we're talking about. 3 of the women in that report were pregnant when they were murdered, and one was murdered by a stranger, one by law enforcement, and one unknown. Murder in general in this country, when women are murdered, it's most often by an intimate partner. The other thing I always like to do is mention Judy Atkinson's book, Trauma Trails, Recreating Song Lines. And the reason I like it, first of all, it's cheap now. It's only $1.99 on Amazon because it's old. And it's also a very important read in terms of understanding the trauma trails, both for Indigenous peoples, but also for those in our own communities who are experiencing the traumas of racism and the traumas of family violence, either child abuse or witnessing domestic violence, and how that goes through our extended families in our communities. The other reason I like that book is Judy is a therapist. So she talks about the kinds of things we can do to heal, as well as the kind of traumas that we experience. Briefly want to introduce my own family. My grandchildren, 4 grandchildren, aren't they cute? And first of all, and the other thing is to point out that young lady in the canoe up there, my daughter, Christy, is a pediatric nurse practitioner, of which I am very proud. And her first paying job was at Children's. So she used to commute down from Baltimore. She loved that job. And that's one of the reasons that I'm so proud to be able to work with you today. The other thing I always want to say is you can see her husband, Nick, there with their two daughters. And one of the things I always like to say is he had to pass all kinds of domestic violence tests before he was allowed to join the family. My son, Brad, over on the other side with his gorgeous, brilliant wife, Nadia, his complaint when he was growing up was not that I would interrogate his dates, although I probably should have, but also that he was not only not allowed to be violent toward a woman himself, but he also was responsible for his friends never being violent toward a woman. And now that he's in the corporate world, he's responsible for his company writing a hefty check every year to the local domestic violence organization, and also for having really good HR policies around domestic violence. And that's one thing for Children's. You kind of have to go back every couple of years and update those HR policies. It's so important that our own workforce knows where they can get assistance if they're experiencing violence in their families from their partners. And the other thing I always like to say about Brad and Nadia is they have these two now adolescent children, but over there in the baseball caps when they were young, one of the things Brad called me one day and he said, "So Mom, we have the big principles. Nadia and I are raising these children to be nonviolent. That's one of our primary objectives in helping them grow up. But we have a problem. At this point, Nathan is bigger and stronger than Layla, and she's not only getting into all his stuff, and this is when she was about 2.5 and he was 4.5, but she's also turned into a champion biter. So in domestic violence parlance, Layla was the primary aggressor. And so I talked to Brad. We tried some things. We brainstormed about some things he might want to try. There's not any quick fix for this kind of thing, but different strategies they tried over time, and gradually she stopped doing that. And this was great. However, it made me think about who is helping the young families in our community, your patients, who is helping those parents raise their children to be nonviolent, especially if those young parents witnessed domestic violence in their own homes. How would they know how to raise them? So that's one of the things that we need to think about from a community basis, from as you interact with young families who are the parents of your patients. Those kinds of things our communities really need some help with, because we continue to have way too much domestic violence and maternal mortality. So as I'm sure you have heard, in the United States, we have far higher rates of maternal mortality than do any of the countries we like to compare ourselves to. And unfortunately, this has been increasing, these rates of maternal mortality. just since 2018, we have seen a substantial increase. And unfortunately, the increase is the greatest and the rates are the highest for Black women and almost as high for Native American women. And they are substantially lower for white, Asian, and Hispanic women. So this is, a clear call to us that we need to look at these disproportionate inequities in maternal mortality. And here we have, as you can see, that the same thing shown slightly differently with bar graphs instead, where the non-Hispanic Black women have far higher rates than other race ethnicities. On this chart, unfortunately, and when you upload different graphics, I'm like, so where are Native American women here? Because they should be right there next to non-Hispanic Black in terms of almost as much increase, and it has continued to increase 2018 through 2021. This is not to say that the rates of maternal mortality for white women and Hispanic women is not too high, because it is, but that inequity is clear in this kind of graphic. So why is this? What is some of the explanations for this inequity? And for Indigenous women, the trauma trails are very clear. There's historical trauma, and also the structural and individual experiences of racism, the structures that have and still do deny access to wealth and to health. We also find that Indigenous women have higher rates of ACEs and also higher rates of intimate partner violence or gender-based violence. For Black women, it's a similar kind of historical trauma. Sotero, if you're ever interested, has a really nice model. She's a social worker since 2006 of historical trauma applied to our cities currently and our inner city populations. Black women also have structural and individual experiences of racism, and structures that have and still do deny access to wealth and to health. Black women also have higher rates of ACEs, adverse childhood events, and intimate partner violence. One of the things we know is that witnessing domestic violence or being abused as a child are the biggest risk factors for someone growing up to use violence against their own partners when they have romantic relationships. And access to quality healthcare varies by wealth. We all know that. Even with what we're trying to do now, it continues to vary by wealth. And when a person, most often a woman, is in a relationship where her partner uses violence against her, this notion of extricating yourself from that relationship or leaving that relationship is far less possible if you are poor. One of the things that I know from working with a lot of abused women is that getting a divorce is really expensive in this country, and that if you're leaving a partner and there's a custody battle, trying to get a lawyer to represent you on that custody battle. And if there's been prior abuse, there's almost always custody battles. And that is really for poor women, a very difficult piece. You in DC, actually, there is a wonderful organization that provides pro bono lawyers to women who need them. And it's oftentimes abused women. And it is one of the wonderful advantages for those of you that live in DC that that's a possibility. And that oftentimes women, in order to address violence in a relationship, they really need that legal representation. So for both Black women and Indigenous women and other women who are being abused, and for me, I am also concerned about the fathers of these babies. One of the things that we in the domestic violence world sometimes don't think about as hard as we should, that these fathers who, yes, are using violence against their partners, but they also are more likely to be killed at the hands of police. They are more likely to be incarcerated by our criminal justice system. And if we think about the wife or partner of this man, even though he may be using violence against her, even if she's not sure that this relationship should continue, that she's trying to figure all of that out, she doesn't want him to go to jail because that's, means that her baby is going to have fewer resources for him or her, that she, no matter what's going to happen in the relationship, she wants her baby to have a father, to have an involved father, to know a father's love and caring. And that's important to that baby's growth and development. So this whole issue of intimate partner violence is very complex. One of the books that I have this reading list for you, sorry about that. But the Beth Ritchie's book is very instructive in terms of how Black women, and it's also true for Indigenous women and many times for immigrant women, are more likely to lose custody of their children, be charged with crimes. They're more often arrested for domestic violence when the police come to a home and there's a Black couple involved. Black women, it's much more likely to be a dual arrest, that they arrest both people if the woman is Black. They're more often arrested and prosecuted for substance abuse. So those are some of the things that we oftentimes don't fully take into account. And so Black, Indigenous, and immigrant women are deeply concerned about calling the police if their partner is hitting them because of this unequal justice against their partner. They're worried about what might happen to their partner and or to them. Will their neighbors hate them if they bring police into their neighborhood? Will his family be angry at her? This is their extended family. This is an extended family support for children. Will they be, if police are brought into this situation, is this just going to heap more scorn and difficulty onto her? And the other thing we always have to remember is that Black and Indigenous and immigrant and adolescent moms to be, that they are deeply concerned. If they disclose abuse to us in the healthcare system, they'll get reported to CPS. And again, that they will be more likely to lose custody of their children to CPS. That there is unfortunately a difficult history with CPS. We want and we need CPS when there's child abuse, but there's also that fear of many women about disclosing domestic violence to healthcare systems. So one of the other realities in the maternal mortality realm is that deaths during pregnancy or in the postpartum, and that's the whole year after the end of the pregnancy, that are unrelated to the pregnancy are called pregnancy-associated deaths. And they're oftentimes not counted in the official maternal mortality statistics. The data that I was just showing you about maternal mortality does not include these pregnancy-associated deaths. They are also, though, disproportionate in amongst Black women and Indigenous women. These are deaths from homicide, suicide, and drug overdoses. And NICHD has some information about that. They are wonderful, part of the NIH that is really done amazing work in maternal mortality. And so that definition, that pregnancy-associated death, is a maternal death, either during pregnancy or in the postpartum year afterwards, that it is attributable to a condition that is unaffected by the pregnancy and occurs within 1 year of the pregnancy. So unaffected by the pregnancy and unrelated to the pregnancy. So something like when a person dies of a hemorrhage during childbirth, well, that's clearly because of the pregnancy. But these deaths, homicide, suicide, and drug overdose, are considered not because of the pregnancy. Well, think about that for a minute. Think about that in terms of, do we think that suicides in the postpartum year, they're oftentimes postpartum depression related, is that not related to the pregnancy? Well, certainly it is. And so, I really push back to this. Oftentimes the drug overdose deaths, the substance abuse is not caused by the pregnancy. The drug overdose is not caused by the pregnancy, but it's oftentimes related to the pregnancy in terms of her maybe trying to stop using substances and then relapsing and using a substance that causes an overdose. We know way too much about the fentanyl in our communities that's available. Well, pregnant women sometimes use it too. And it may be complicated by the pregnancy, if not that overdose death, if not caused by the pregnancy. We all know too that newborn babies it's tough in that newborn stage in terms of being a mother and how we address this, especially if we don't have a lot of financial resources. So these things are very complicated, and to totally dismiss them as being unrelated to or unaffected by pregnancy is very questionable. The homicides also, and this is of course, most of these homicides are intimate partner homicides. I contributed to a review that was done of maternal mortality for Indigenous women. And they looked at those pregnancy-associated deaths. There's a lot of reviews, systematic reviews of maternal mortality that do not include these pregnancy-associated deaths. And in that review, they only found 8 studies that even considered American Indian, Native American women who were killed with a homicide when their pregnancy. Only 8 in a whole 20-year span. So we definitely need more research about this. We definitely need more documentation. And as I mentioned, that missing and murdered Indigenous women initiative is one way to try and get at that. And oftentimes, even those studies that do consider Native American women, they lump them into an other category. So the very low percentage of these homicides, especially when we consider the disproportionately high rates of domestic violence amongst Indigenous women that we do know about. Only 9 studies investigated Indigenous Native American maternal deaths by suicide. And that's American Indian, Alaska Native. I'm sorry, I had a tongue twist there. And again, most of these studies are lumping Native American women into other racial ethnic groups. There was one study, the Palladino study, did consider American Indian, Alaska Native women separately, and found that these suicides were disproportionate during pregnancy or in the postpartum period for Indigenous women, but others either use that other category, other studies, or they did not report the risk for American Indian women, which again seems unusual and points out that there needs to be much more research, because we know that suicide is very high amongst Indigenous women. It may be, though, that Indigenous women do not kill themselves during pregnancy or in the postpartum as differentiated from suicides during other times of life for Indigenous women. Again, desperate need for more research in this area. And I know that for us in Baltimore at Johns Hopkins, for you at Children's, you have a tiny proportion of your patients who are Indigenous, but those who are really need particular attention and a culturally appropriate and informed attention. And the other review that was done was one that I was a part of, and that's actually lead author on this one. We did a deep dive into studies where there was homicide, as well as suicide or substance or drug overdoses during pregnancy or in the postpartum. When we look at other homicide studies, approximately 5% of women who are murdered by intimate partners are pregnant when they're murdered. So this is when we look at intimate partner homicide overall versus pregnancy-associated deaths. And in that review, though, when it was the woman was murdered, who died during pregnancy, 8 to 25% of them who died during pregnancy or in the postpartum die from homicide. Now that's a wide variation, up to 25%. But no matter what, a chunk, a non-trivial proportion of women who die during pregnancy from all causes die from homicide. Among women who are murdered while they're pregnant, approximately half of them are murdered by partners. That's true when women are murdered overall in this country. Black women are definitely disproportionately affected, probably Indigenous and immigrant women, but there were not enough studies that considered Indigenous women to be able to see if they're disproportionately affected. And one of the consistent problems, and this is a policy thing, is that even though medical examiners, when they do an autopsy of a murdered woman, are always supposed to check off, there's a pregnancy checklist and checkbox. And it says, was this woman who has been killed and we're doing an autopsy, was she pregnant when she died? And then there's checkbox, yes, no, or there's no third option. She's either pregnant, she's not pregnant. And oftentimes those pregnancy checkboxes are not filled out. This is one of those, policy things that somebody needs to be checking for, that pregnancy checkbox. If medical examiners aren't doing that, if they're not making a check, if they're not doing an assessment for pregnancy, they should be getting fines. They should be getting reprimanded. This needs to stop if we're ever going to keep track. And one of those is, especially it seems to be missing in homicide, suicides, and substance use disorders, deaths by overdose. One of the things that's always amazing to me is that, again, that it's not done, and that some medical examiners are like, well, if she's not obviously pregnant when they do the autopsy, I can't tell. And if, for instance, and this is graphic, but if she was shot in the head, so I can't tell if she's pregnant. And that's what now I'm looking for cause of death. So I'm looking at the gunshot wounds, and I'm like, excuse me, you could do a pregnancy test. You have urine available. It's not that hard. So I just don't understand. And somebody talked about the cost to me, a medical examiner, of a pregnancy test. I'm like, excuse me, they're not that expensive. So this is one of those things that if we don't track this, we'll never know how bad of a problem it is. In national data, and this went through, was published in 2005. So it was a while ago, but even so, you can see there that homicide was the second leading cause of maternal mortality. This is considering maternal mortality from toxemia, from hemorrhage, all the physical causes. This is ranking right in there. It was the second leading cause of maternal mortality after automobile accidents, and firearms were the most common mechanism. And this was disproportionately present in Black women again. Again, in a study that was done in Maryland, and it was published in 2010, and it was one of the best studies actually, I'm from Baltimore, so I can brag about Maryland. It's one of the best studies of maternal mortality, where the homicide and suicide was also considered. And we found that homicide was the leading cause of maternal mortality in Maryland in that time period. And again, Black women, disproportionate firearms, the most common method. More than half of those pregnancy-associated homicides were intimate partner homicides. And if you didn't look at the open cases, the ones that hadn't been solved, 65% were intimate partner homicide. And half of it was during pregnancy, and then the other half after the pregnancy ended. And all of the women who had a live birth in this period of time in Maryland had received prenatal care. The point being there that if we were asking routinely, as we're supposed to as healthcare providers, about intimate partner violence, we would have been able, hopefully, to prevent some of those homicides. And sometimes in those cases, actually, it was directly linked to a pregnancy. There was one case where this man was married, and he was having an affair with another woman. She got pregnant. He wanted her to have an abortion. She refused to have an abortion, and he murdered her. And one of the things that's happening in Illinois is they actually passed a state law mandating that the state maternal mortality review panels review homicide. I know that in Maryland, our maternal mortality review panel, those are set up to review those other causes of maternal mortality, not homicide, not suicide, not substance use, substance overdose. But in Maryland, we do review those pregnancy-related causes of death. In Illinois, they had to pass a law to mandate that the state maternal mortality review panel review homicide. And I meant to look, but I think one of the things we should be checking on is whether or not the DC maternal mortality review panel actually does review these deaths from homicide, suicide, and overdoses. And what about Virginia? Does that maternal mortality review panel review these causes of death? And so we also need to consider suicide. I think I've mentioned it a bit. There was one study that estimated that suicides account for up to 20% of postpartum deaths. One of the things we know is that suicide for the intimate partner violence is the strongest risk factor for suicide attempts globally. And it's also been shown to be a strong risk factor for suicide for Black women in the United States. Again, the substance use disorder, the overdose deaths, fewest number of studies, but clearly one of the issues we know that overdoses is a major cause of death in our country. All of these, the suicides, the substance use disorders, are all significantly associated with intimate partner violence, just like the homicides are. The National Violent Death Reporting System compiles all of the violent deaths from homicide and suicide in this country. And there were in this study, there were only 17 states that were contributing to it. Now in 2023, all 50 states are contributing to the NVDRS. So this is a good source of data. However, you have to request it and then do the coding, etc., in order to get a reasonable report. I was on this study in 2011, and we're trying to replicate it now with all 50 states. But again, homicides, 45.3% of these causes of death from maternal mortality and pregnancy-associated deaths. The homicides were all intimate partner violence related, or 45% of them were. The 42% a partner or former partner murdered the pregnant woman. Black women were disproportionately affected. Again, in this study, there was too few Native American women to actually compare. Suicides, 54% of those were intimate partner violence related. So you can see graphically there, homicides, a greater proportion of causes of death in those 17 states, a greater number, and this is per 100,000 live births, than suicide, and suicide was number 2, and hemorrhage was number 3, eclampsia number 4, and embolisms number 5. And again, graphically, this is Wallace's study, really graphically showing that the homicides of pregnant women slightly higher than the homicides of non-pregnant women, suicides of non-pregnant women higher than pregnant women, but still per 100,000, these are high numbers. And this is another comparison, homicide being greater than hemorrhage and placental disorders. This was also done with birth certificates and death certificates, and finding higher rates of homicide than hemorrhage, hypertension, or sepsis. So I hope I've convinced you. Homicide is really important in terms of a cause of maternal mortality. And what do we know about intimate partner violence around the time of pregnancy? Since intimate partner violence, those homicides are primarily by intimate partners. One of the things we know is that there are different patterns of abuse around the time of pregnancy. So way back in 2003, these categories were identified. There's abuse during pregnancy. There's intimate partner violence while the woman is pregnant. There's also abuse before pregnancy, the 12 months prior to the pregnancy. There's abuse around the time of pregnancy, which includes women abused before or during pregnancy and or both. Abuse during the year of pregnancy, that's the 12-month period during which a pregnancy occurred, and abuse after pregnancy, abuse during the postpartum pregnant period. So with all this different terminology, it's no wonder that when somebody says, how many women, what proportion of women are being abused during pregnancy? Well, it depends on what part of the pregnancy period that you're counting. And this was a study that was done using PRAMS. Now, PRAMS is that if you've been pregnant lately, you get a survey after the pregnancy, a questionnaire, and people are asked questions about the pregnancy. And one of the questions is, were you abused by your partner during pregnancy? We always get a lower rate of abuse when you're looking backwards, because the baby's born now, and if there were difficulties during pregnancy, you've forgotten them or minimized them oftentimes. Even so, we find that there is more abuse before pregnancy than during pregnancy. One of the patterns we see is that many times abusive partners want that baby. They are trying to protect the baby during pregnancy, and so they don't actually hit her during pregnancy. This is another graphic representation showing the same kind of thing, where we have more abuse before pregnancy than during pregnancy. And if we count the abuse both before and after pregnancy, then we have a higher rate. This one is instructive because the other are other people abusing or hitting a woman while she's pregnant or during, before pregnancy or during. For adolescents, this is oftentimes parents. So sometimes we forget that part. And we need to always, when we ask adolescents if they're being abused during pregnancy, when we talk to pregnant adolescents, we need to be sure to ask if anyone else is abusing her as well as a partner. We used to think, and some people still do, that pregnancy is a risk factor for abuse, that there's more abuse during pregnancy than before. Actually, it's more often a protective period. As I said, many abusive partners are less abusive during pregnancy, at least less physically abusive during pregnancy, but it oftentimes starts up again afterwards. But what we have found from my research is that if he actually hits her during pregnancy, this is a risk factor for homicide. This is a more dangerous abuser. And we need to be able to identify those high risk cases where she's at risk for homicide. One of the things, if the abuse lessens during pregnancy, gives her more hope that everything's going to be okay when the baby is born. But as I mentioned, oftentimes it will start up again, the physical abuse, because of that highly stressful period after pregnancy. This is a depiction, and this study was in the DC area, where we graphically put the overlap around physical, emotional, and sexual assault. This is not during pregnancy, but we see the same kind of overlap when abuse happens during pregnancy. That almost every woman who is physically abused is also psychologically abused. There's a great overlap between the two. And sexual assault, forced sex during pregnancy happens the least often, but that you see that 18.7%, 166 women were experiencing all three: psychological, physical, and sexual assault. And this was not during pregnancy, but that when they experience all three, there's much more health problems. Now, this is a very busy slide, and I'm not going to talk about all of it. However, one thing to remember, and you can have access to these slides, I'm happy for you to do so, but to remember that there are a multitude of physical health effects from being abused. They are more problematic if this woman has experienced adverse childhood events, that it makes these physical health effects from domestic violence even worse. And that part of these are around reproductive health, that we see more postpartum depression amongst women who are abused, more low birth weight and preterm births, more small for gestational age infants. This means that some of these infants that are in our NICUs are in part there because of domestic violence. So it becomes really important that even as much as we want fathers in the NICU, that we want fathers in delivery, we always need to figure out a time to get her alone and ask her about the abuse, especially knowing that those patterns can change around the time of pregnancy. We also have a lot of gynecological problems. We have a ton of chronic pain, and that can contribute to those substance use problems that women have. And that's a combination of injury and what happens in your brain if you're continually traumatized, that this it includes some effects on your HPA axis, 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 things like fibromyalgia, etc., can be either caused or highly exacerbated by intimate partner violence. Old injuries that are never correctly treated. We see a lot of traumatic brain injury in abused women. Sleep problems is the thing that they most often complain of, and that's a combination of physical and mental health issues. We see more PTSD, more depression, more suicidality. And, if you lay that on top of the childbirthing woman, that's when you see that postpartum depression, etc. Those exposed to intimate partner violence, 50% more likely to experience fetal loss compared with women who are not abused. This is some physical health problems from that PRAMS questionnaire. Women who reported intimate partner violence the year prior and or during pregnancy were at increased risk for high blood pressure or edema, vaginal bleeding, severe nausea, vomiting, or dehydration, so that that kind of pregnancy-associated nausea and vomiting that continues throughout the pregnancy, the morning sickness. Urinary tract infections, hospital visits are increased, delivery preterm, low birth weight infants, as I mentioned, as well as small gestational age infants, and infants requiring intensive care unit, NICU treatment. And again, this is a more recent study from PRAMS. Somewhere around 4% of women on the PRAMS thing reported physical intimate partner violence in the 12 months before and or during pregnancy. Fairly low percentage. We see higher percentages when women are actually individually asked by a prenatal care nurse or nurse home visitor. Very much associated with being enrolled in WIC, with being unmarried, with being relatively young, with having an unintended pregnancy, smoking, and we see that's somewhere between twice as many women smoke during pregnancy. Very complex part of why they smoke, why they find it so difficult to quit when they're being abused. It's, we can think about it in terms of the inhaling and the deep breathing, that is a way of the body managing stress. Is that part of what happens? And the association with prenatal counseling on depression. So I alluded to screening, asking about intimate partner violence. There's really good evidence that screening increases disclosure. If we don't ask, women do not tell us about abuse. And we do have interventions to reduce intimate partner violence. Screening does no harm. Asking about it, that's been tested, and there's no harm. But If we just ask and don't provide an intervention, that doesn't help. I don't know why anybody thought it would, but we need to do more than usual care. We need to do more than just giving somebody a phone number, a national domestic violence hotline number. The abuse assessment screen is one that's been widely used to screen for abuse. It has 5 questions if she's pregnant. Versus 1 question. People want to ask 1 question. They want to ask, are you safe at home? As if people understand you're talking about people in the home versus smoke alarms or whatever. It doesn't take that much longer to ask 5 questions. The first one, emotionally or physically abused within the last year. Have you been hit, slapped, kicked, pushed, or shoved? That's the lowest level of physical violence. It's really important to have that in there, not just asking about hitting. And otherwise physically hurt, just takes a few more minutes to put that in there. And then did it happen while you're pregnant? As well as within the last year, that number 2 question. So it's important to see that covers before pregnancy. And then the forced sex is a separate question because she doesn't oftentimes think about that as part of the hit, slap, kicked. And number 5, are you afraid of your partner? So whatever that partner does to you, I always think about the study that was done in part in Texas. And some of the Hispanic women said yes to the, are you afraid? And the nurses asked, how come you're afraid? And some of the women said, he throws knives at me. He would never hit me while I'm pregnant, but he throws knives at me. And so that's the other thing that, to give that kind of open-ended question that you don't have to, so that you can capture women who are afraid of him for whatever reason. Remember, it doesn't really matter what you say, it matters how you say it. When I always say what you say first, pause and say it slow. This is not part of your, you have this whole history form that you have to fill out. So say something like, because domestic violence happens to so many women, and because it affects babies before they are born as well as after. That's why we're asking. And so we're going to ask everybody. Many times, especially for those adolescents, you need to assure her you're not going to report her to CPS or immigrant women. You're not going to report her to anybody, and that you make eye contact rather than looking at the computer screen. And needless to say, you have to do it with privacy. You can't do it in front of women. So Futures Without Violence has a wonderful website on how to ask, what to do in terms of a warm referral when you ask. And it's got all kinds of information for providers. It's got things you can, signs, posters you can put up, or little cards you can give. You have to be careful in terms of giving her stuff to take home because of abusive partners wanting to look at stuff. But if it's part of a bunch of stuff about prenatal care, that's okay. If women disclose, they're 4 times more likely to use some sort of intervention for domestic violence, 2.5 times more likely to exit. But we always have to remember she may not want to leave, and we may need to be able to help her stay safely. I'm going to just mention briefly, because I'm out of time, the Dove intervention that's available. Phyllis Sharps, my colleague, developed it. It does decrease intimate partner violence. Our homicides are going up in this country. The danger assessment is what I developed that helps us work with her to see how much risk she's at. There's a short form for clinicians. All of this is available on the danger assessment website. That's www.dangerassessment.com. And there's also the My Plan app. My colleague Nancy Glass developed that. That's available in the app stores. It's really good for anyone that's abused or is in a relationship and they're not sure it's abusive. We do need a lot of things to do around midwifery care and doulas on culturally appropriate care. But we also need to think about gun locks in terms of them going home with new infants. We know now that gun injury is the leading cause of death for children. And we need to have some interventions for the fathers that work early. This is just a couple of quotes from people. A mention of new offender intervention programs that are include fathering, but also particularly ones that can be done early when abuse first starts, so that we don't have to wait for people to have to be arrested. So I see I got a bunch of folks, the questions in the chat, and I know it's time for you to go. So I thank you very much, and we'll do some answers in the chat. Looks like there's not too many questions, but we'll provide answers by email. So thank you very much for being here, and have a good rest of your afternoon.